Okay, now? Okay, good morning, everyone, again. So it's really my pleasure to kick off this half HTA day today, which is happening the first time in this workshop. And on behalf of the whole scientific subcommittee, we are really happy to have the possibility to have some dedicated sessions to HTA and to have some exchange there. So as you all know, the European HTA is around the corner. The official start is January 2025. And the HTA, the clinical assessment for HTA, will be run fully in parallel to the regulatory approval assessment. And we have to submit the dossier 45 days before CHMP. So there will be a huge bunch of evidence out there, and we are really happy to foster discussions around methodology for that now with those dedicated sessions. So unfortunately, we have to announce a change in the program. David McConnell cannot come today, he's ill, but we are looking into opportunities to have him speak in a webinar or so. So we will let you all know once we have figured out. So the first speaker today is Lara Wolfson. She's currently the head of HTA statistics at MSD. She has had a diverse career path. She had roles as value evidence strategy leader in Vic Science at the Merck Center for Observational Research and Real-World Evidence, and in global public health and global market access at Janssen. She holds an MSc and PhD degrees in statistics from the Carnegie Mellon University. Lara is also the co-chair of the EFSPI-PSI HTA-SIG, and she's extremely engaged in the European HTA implementation and the methodological aspects of that and brings a lot of experience. She's talking about a lot of P's, so proper prior planning for the pre-specified post-hoc analysis of PICOs. And with that, I want to hand over to Lara to kick off the session, and hopefully we have a great discussion. To let you know, we will have a very long panel discussion at the very end of the session. So we will have 3 presentations. So keep your questions in mind for after the break, and we will do a panel discussion then. Lara, the floor is yours.
Thank you. So good morning, everyone. There are a lot of P's on this slide, and you're going to see that theme throughout this presentation. And hopefully this is all making you think of a well-known adage that my mother often said, that proper prior planning prevents poor performance, or proper prior planning promotes proper performance. And so in this case, I am going to explain why I chose some of these things, but it's really an interesting time with what's happening with HTA right now. And I'm going to take some time and explain a little bit about what HTA is and why it's a little bit different from the regulatory context. And let's see if we can move the slides. Am I pointing at the wrong place?
No, it's really neat. No, it's stuck. It's like
Okay, while they're doing that, I'll give you the usual disclaimer that the views I'm about to present are my own and not those of my company. Although I will also give credit to the many, many people, both at my company and in the EFSPI-SIG and in the European HTA community, who I have talked to and who have given me many great ideas that have helped me prepare this presentation. Okay. Fortunately, I know some of the early slides well enough that I can get there. But I will take this opportunity to talk a little bit about why I chose some of the themes for the talk I did today, because at the end of the day, all of what we've been talking about for the past 2 days and even today is about decision making. Everybody wants to make good decisions. Everyone wants to make the right decisions. And everyone is also afraid of making the wrong decision. And so we all have techniques we use to try to make sure we're making the right decision. So how many of you have a policy that says that before I make a major decision, I'm going to sleep on it? Okay. And we all have little techniques we use. And as statisticians, we have techniques called statistical methods that we like to use. So a lot of what HTA is about and what regulatory analyses are about, they're all about making the right decisions. But it's also about knowing the framework of what's the decision I'm trying to make. And so here's one of the challenges is that the right decision for one person is not always the right decision for another person. And part of that challenge is linked to the fact of what's the decision you're trying to make? What's the question you're trying to answer? Okay, so a regulator, in regulatory context, when we do drug development, the question we're trying to answer is, are we able to develop a drug that we can show has a favorable benefit risk profile? That's the question. We're looking at, compared to at least one other alternative that's approved, is there a favorable risk benefit profile? That's not the same question we're trying to answer in health technology assessment. In health technology assessment, we're starting to ask a different question, which is, where does this treatment fit in the landscape of all other available treatments? Not just, is it good, but how good is it? And the problem is that this is not an easy question to answer. Okay, up and down. Okay, I can do that. So when we talk about regulators versus health technology assessment, one of the challenges we're having is that we have a clinical trial or maybe several clinical trials that have been run, and we want to use the same data in very different ways to answer different questions. On the regulatory side, we're answering a question of, is the risk-benefit profile adequate? There's a common source of outcome that's absolute. Is this product safe and effective? And the requirements are relatively transparent and seek to be minimal, and it recognizes that clinical trials have limitations by design. When we flip over to HTA, we're starting to ask, how good is it? And that outcome becomes very contextual and relative. How much more effective or safer is this product than alternatives? Is this an appropriate therapy in our unique setting? So it feels like the requirements are opaque and intensive because we're starting to ask questions of what do we see as increased benefit? Well, a lot of that has to go with what's it relative to? And what is the added benefit meaningful? We have to look at values versus costs. On the regulatory side, you can say, we're going to take a drug and make it available because you don't have to address the question of what's not going to be available because we're paying for this drug. We can just make as many drugs available as possible. In fact, we want people to have that choice. But on the HTA side, what's often happening is that we're dealing with limited budgets, we're limiting with choices, and we're trying to figure out exactly where in the continuum of all the choices that you have, does this drug fit? And so in order to do that, we want a decision framework. And one of the ways of doing that is to say, okay, let's take the data that we have available and relook at it to see how we can use it to answer this question. And so it feels like we're doing ad hoc reanalysis of clinical data. But HTAs are an integral part of the pathway leading to patient access. So this is a bit of an oversimplified diagram because a lot more things are happening in parallel, as Katrine mentioned. But you have clinical development, and then you go to regulatory approval, you have health technology assessment, then you go into pricing and reimbursement, and then patient access. Now, in reality, these things are all happening in parallel, but HTA informs decision-making about reimbursement and pricing, and we're trying to balance budgets and resources in individual healthcare systems. So it's a multi-stakeholder process that can be both internal and external. And there's also different types of HTA systems. And one of the ways that they're often characterized is systems that are based on clinical effectiveness. So that's the German system where the question is, can you demonstrate that there's a clinical added benefit? In the UK system, it's very cost effectiveness focused. So the question is, can you demonstrate that the cost effectiveness of this drug meets a certain threshold? And then you have hybrid systems that have elements of both, and France a good example of that. And more than 60 countries claim to have formal HTA processes. Okay. Okay. So the slide that I was about to show you was a screenshot from a paper that's showing the diversity of HTA systems. And it actually doesn't even fully get that one. Okay. Capture this. So this is from a recently published paper looking at health technology assessment systems across more than 27 countries. And there's a couple of things that are really important to understand about HTA. Different systems have different data requirements, ranging from that comparative effectiveness archetype to the cost effectiveness archetype. They have different timings. Some of them actually will make some reimbursement decisions even before there's a regulatory approval. And some of them will not make it until years later. They have different issues around the nature of the HTA recommendations. Are they binding? Are they non-binding? And they also have different relationships between regulatory processes, HTA body recommendations, and pricing and reimbursement decisions. So there's no one size fits all, just like there's no one size fits all framework for the decisions we all make in our everyday life. So let's talk a little bit about HTA data and analysis, because we are primarily an audience of statisticians. So how does randomized clinical trial data get used in HTA dossiers, and what analyses are done by HTA statisticians? Well, here's where the way that we use data for HTA is kind of like a system of building blocks. We start with direct inclusion of the regulatory submissions documents, the clinical study reports that you may provide as part of your dossier. But then we start to take the data apart a little bit more. Let's look at some subpopulations and groups in the data specifically relevant to individual countries and their treatment patterns. So I was recently, just this week, looking at a data set from one of our clinical trials. And in the data that we had from this clinical trial, 70% of the population was Caucasian and 23% was Asian. But it was going to be used in a setting where only 5% of the population was Asian. So does it make sense to have data from a clinical trial that has 4 times as many Asians in it and make conclusions based on that? Or should I be reweighting the analysis? Or should I be looking at it separately in the subgroups when the actual population of patients that's going to take the drug is different from the ones that were studied in the trial? So the next thing we might do is we often do the health economic models. When we do health economic models, we often have to take the data from the clinical trials and extrapolate it beyond the time that we studied it for. So we might study a drug for 2 years, and we in oncology will get some data on overall survival during that period. But what people are interested in is, what is the 5-year effect of the drug? What's the 10-year effect of the drug? What's the lifetime effect of the drug? And so sometimes we have to extrapolate that. We might have to analyze the data in different ways in order to put it into a health economic model. And finally, we often want to do combined or comparative analyses. When you make a decision about buying a car, you don't necessarily just want to know the data about the car you're going to buy. You want to know things about the general reliability of the brand that you're buying. And by the way, if I'm buying an SUV, what's the average gas consumption of the SUV compared to the sedan? And so there's all kinds of questions that you might ask, and you might want to look at overall data. So we often do combined or comparative analyses. And in particular, what's happening now, especially as treatment landscapes are evolving and the number of potential treatments and therapies available to people are multitudinous and variable. When we run a clinical trial where we looked at one standard of care, people want to know, can you look at the totality of the data? Can you do pooled analyses? Can you do meta-analyses? And by the way, if the standard of care changed between the time you started the trial and the time the trial reads out, can you do an indirect treatment comparison? Because I'm not interested in how the drug worked against a standard of care no one's using anymore. If I, as a patient, am going to take a new drug, I want to know how it works against the other alternative that's available to me. So we want to use the RCT data from all the relevant RCTs, but we're often looking at new populations, comparators, endpoints, and specific methods. And I'm starting to talk about the patient for a very particular reason, which is that a lot of what's happening with European HTA is actually about the issue of trying to get that bridge between what is it that people, what's the data that we have, and who are the people who have to make the final decisions? We need to look at the patients. We need to look at the healthcare providers. We need to look at the payers, not just at the drug developers and the regulators, because they're part of the decision-making process. So briefly, why do we use indirect treatment comparisons? I'm not going to go into great detail here. This was part of what David was going to cover in his talk, and so I don't want to steal the thunder of the eventual webinar we hope he'll eventually give. But the idea is that sometimes I couldn't do a randomized clinical trial against the comparator people are interested in. So I'm trying to get there indirectly. And so there's a lot of comparative evidence options for HTA submissions, and a lot of it involves careful thinking and planning of, can I do the analysis? So indirect treatment comparisons are all about choices and what's available. In an ideal world, we run an instantaneous clinical trial on the date, and we know a new drug is safe as effective, and we compare it to all the other treatment options. Now, that's not really going to work, right? Because I need to study it for 5 years to actually know all of the effects and the comparabilities. But then I also say the question, do I have aggregate data available? Do I have patient-level data available? Do I have both? What's the evidence structure that I have if I'm trying to draw connections between different trials? Do I have anchored or unanchored designs? What are the number of therapies that I'm comparing? Am I looking at just comparing 2 treatments? Am I looking at comparing 3 treatments? Am I looking at comparing 10 treatments? And by the way, when I want to compare data across a lot of different clinical trials, I have to look at questions about population heterogeneity. How were the populations selected for these trials? Are they different? Are they the same? But how do HTA bodies view these indirect treatment comparisons? And I feel like we lost some. The acceptability of these methods vary across HTA agencies. So I'm going to talk a little bit about EU HTA in a moment and explain how it's going to work. But one of the problems with EU HTA, or one of the advantages of EU HTA, is that we're going to try to have a common core data submission, common core set of analyses that we submit that go across multiple countries. Okay? But what I want to point out to you here is that 2 of those countries are Germany and France. That's IGWIG and Haas. And if I have to do an indirect treatment comparison as part of my HTA submission, and I want to make Germany happy, I'm going to do a Boucher indirect treatment comparison. But that is not going to make France happy. So what do? Do I do both? Do I just choose the statistically best method and then accept that I might have to do something different in the national submission? There's lots of different choices of ITC methods, and this is going to be one of the challenges that we're facing as statisticians in the world of EU HTA. So what is EU HTA and how does it change things? Well, there's a long history of collaboration leading to the EU HTA regulation, because I think everyone recognized that different countries may make decisions differently. But at the end of the day, the underlying data that they're looking for is all coming from the same place. So in the last 20 years, there was UNETA, which was a voluntary collaboration. The group formally closed in 2023, and I feel a bit weird being the one talking about it because Wim, who's been involved in it since its inception, is sitting right there, but he'll talk to you shortly. But it was a fabulous collaboration that eventually led to a regulation that is called the EU HTAR. So it's really important to realize UNETA and EU HTAR are different. The EU HTAR builds on UNETA, but now we have a formal regulation rather than voluntary cooperation. So it was passed into law in Q4 2021. It takes effect starting in 2025. There's a rolling implementation period determining which types of drugs are subject to it, but it becomes a mandatory requirement for centralized clinical assessment, and it's meant to facilitate patient access for new health technologies to member states of the European Union. And it's really important to recognize that the ambition of the EU is an ambition that's shared by drug developers. It's shared by statisticians. It's shared by everyone involved in the process and patients as well. Faster and more equitable access across Europe through higher quality and more efficient HTA across the European Union. So what is a centralized assessment going to look like? Well, today, you submit to the European Medicines Association, you get marketing authorization. And then in the individual member states, you work with HTA bodies to get a decision, and then you work with payers for pricing negotiations. Under the EU HTA regulation, you're going to get the marketing authorization, and in parallel, the HTA coordinating group is going to do that joint clinical assessment, making the data necessary for the individual member states to start to make their decisions available contemporaneously with the regulatory approval. So instead of having to wait potentially up to 5 years to get data submissions from manufacturers, a lot of the data that's necessary to make decisions is going to be available right at the time of marketing authorization. So the key elements are there's a single core submission of clinical information, data analyses, and other evidence that's required for the joint clinical assessment. It's meant to be inclusive of all 27 European member states' need for data. There's a joint clinical assessment report that be as an input into national HTA processes, but value decisions and health economic assessments remain at the national level. And there's also opportunities for joint scientific consultation to get early HTA scientific advice with or without parallel EMA advice. So how do PICOs come into this? Well, the assessment scope for JCA is all about the PICOs. It's the patient population, the intervention, the comparators, and the outcomes. PICO selection is policy-driven and not evidence-driven, and member states are free to determine their PICO needs, but there will be a consolidation of the requirements. What are the consequences of this? Well, if you think about the variety of the treatment landscape across European countries today, it means that there could be more comparators and more subsetting of populations than we actually see in phase 3 trials. And there's going to be a large volume of these indirect treatment comparisons. But that data is going to become publicly available shortly after regulatory approval. And it may not just be about the JCA PICOs, but there may be additional PICOs that have to be answered in national Delta dossiers. There will still be submissions at the national level. They can't be of exactly the same data that's part of the JCA, but they can be supplemental. What are the challenges? Well, firstly, drug developers are not involved in the PICO determination process. That sits at the EU level. And that makes planning for the analyses a little bit tricky because you're trying to predict something that you don't control. But we're good at that as statisticians, or we should be. PICOs are therefore going to have to be estimated internally for JCA dossier planning, and there could be a substantial volume of them. And so here's the thing. As human beings, sometimes we like to have rules, but we also don't like rules. So on the one hand, we want to know, what am I supposed to do? But I only want to know what I'm supposed to do as long as what I'm supposed to do is what I want to do. Okay? If in fact I don't like the rules, I don't want there to be rules, but I would prefer that there were rules as long as I like them. So, this is the reality. Okay, so we kind of got our wishes here. We have some rules and we have some flexible room. So there are requirements in the JCA dossier template. They're coming through the implementing acts and guidances. But when it comes to methods and approaches and the choice of what evidence and references we provide, we have some flexibility. And then there's going to be the national dossier's impact, and that's going to be very country specific. So every health technology developer is going to get to make their own decisions about methods and approaches and evidence and references. They just have to justify it and explain it and convince people that they made good decisions in what they chose. And so there's one key requirement that's really important. All of your statistical analysis plans have to be included in your JCA submission. And so that takes us to the question of, okay, and what does the timeline for that look like? Well, it's tight. I'm not going to walk you through all of this. There's lots of great webinars that are being given. It's being talked about lots of times. But the most important thing is what I'm going to show you between the final PICO that you are going to get when you get it around the day 120 part of the regulatory process. And you have 100 days between that final PICO and when you're submitting your JCA dossier. So you are not going to know what populations and comparators you're looking at for sure until that date. Now, Most of us who work in production of these kinds of dossiers know that it's not as simple as just doing the analysis, because you also have to do the analysis, you have to interpret the analysis, you have to validate the analysis, you've got statistical programming that needs to make sure that there's traceability and accountability. And oh yeah, there's writers. And the writers don't like getting things at the last minute. They would like time to think about it. There's a lot of people who want to review this before it goes in. So if you're not doing your analysis until the day you get your PICO, you're not going to get done on time. And that is why we say, why do we know there's going to be a lot of indirect treatment comparisons? Well, FPA and Evidera did some initial scoping work, and they tried to look across 3 different products, labeled here as X, Y, and Z, to see how many different populations and comparators and outcome categories were there. And when they got to the consolidated PICOs, you can see the range. It goes anywhere from 6 to 57 per dossier. So we're guessing probably 10 to 15 on average. It's a lot. But think about if there's 57 possibilities and you're doing the planning and you don't know which of those 57 are going to show up. You don't want to do 57 of those in a 100-day period. And here's the other thing you got to think about. And this is probably the most important slide I have. PICOs mean different things to different people. So I'm back to my subject of Ps here. You have the preparer, the drug developer. You have the approver or the regulator. You have the payer, the HTA. You have providers, doctors, and you have patients. We all have different definition of populations, okay? Drug developers, here's one thing that's really important to recognize, and many of you who work in industry, many of you who work in regulatory and HTA, you know this. People who are developing drugs are doing it because they believe that they found a drug that's really going to help people. They want to help as many people as possible. So their definition of population is really broad. But when you're a patient, you know what your definition of the population is? Me. I want to know that for a 53-year-old woman of Jewish Ashkenazi descent with my particular comorbidities, is this drug going to work or not? Is it the best choice for me? Okay? But when I'm developing a drug, there's 200,000 versions of me. I want to test that drug in a variety of people because I want to know if it could work for all of you. And then when you talk about comparators, for the drug developer, for the regulator, we all agree we're going to pick a comparator. We're going to pick a standard of care. We're going to evaluate, can you show a risk-benefit profile against that? But when I'm a patient, I want to know, there's all these different treatment options I could have chosen. How does it compare to all of those? Because go down to the outcomes. When we're doing the regulatory assessment, when we're designing the clinical trial, we are focused on one thing. Can we demonstrate safety and efficacy? And how do we define that? And we pick a few things we're focusing on. But you heard yesterday, different patients have different preferences, different risk tolerances. And so the variety of outcomes that you might want to look at, not only are they different, but you might weight them differently. And so that takes us to, how do I plan for all of this? If different people have different perspective on populations, on comparators, and outcomes, why do I do it? And why am I calling it pre-specified post-hoc analysis of PICOs? So we got to address the needs of all these stakeholders, and we have to be smart about it. Specific, measurable, achievable, realistic, and time-bound. So I called it pre-specified post-hoc analysis because I have to have an SAP, but it's not the same as my regulatory SAP. Post-hoc analysis in this case means post-hoc to the alpha allocation in the trial, and post-hoc because it's not in the trial SAP. I'm not going to have specified it at the time that I designed the trial necessarily. Pre-specified here is talking about the fact that I'm going to specify the analysis per PICO before the database lock, but not necessarily at the time of protocol development. And then I also have to worry about that time-bound issue because one of the things that's been specified is those systematic literature reviews that are going to lead me to the indirect treatment comparisons. They have to be current within 90 days of the submission. So I'm going to have to update them at the last minute, and I have to plan for that. So what is proper prior planning going to look like? So this is one view of general and EU HTA milestones. So the way that we put this together is we looked at 4 elements. We looked at the regulatory milestones, the general milestones, and the EU HTA preparation milestones. And EU HTA preparation starts at the time of the development of your late development program approval. You should actually be thinking about this before first patient in. That's what FPI means on this graph. So your PICOs and your strategy for your JCA, you start planning that as soon as you know you're doing a late development program, not right before you do your HTA dossier. And by the way, your SLR, looking at the universe of potential comparators and populations you might be looking at the treatment landscape across Europe and maybe beyond Europe, because that could influence how the treatment landscape in Europe evolves. You're starting to plan for that alongside your clinical development program. Your JCA specific dossier planning and development, you probably start that around 24 weeks or 6 months before the database lock. But you also have to plan for your non-JCA HTA analyses planning and development because you need to make sure that those are consistent. So there's a lot of planning here. We break it up into different time periods in the phase 3 registrational study development, in your decisions and your timing for your regulatory filing decision, and then your HTA and reimbursement. And proper prior planning means that you're going to break this down. Now, that breakdown is probably going to look different in every company. This is a view of how we're planning to do some of it. But we start to break it down into very specifics. How are we going to anticipate the PICOs? Are we going to get a first list of PICOs? We're going to actively monitor and update them. We're going to have final anticipated PICOs, and we're going to prioritize them, because if there's 57 of them, we may not be able to do 57 analyses or 57 dossiers, but we're going to try to guess at which ones are the most likely and be prepared for that. Our JCA strategy, again, we're planning for this all along. So we're planning for bringing in data from systematic literature reviews and indirect treatment comparisons. And we're going to have protocols that we do for that. We're going to do feasibility assessments. We're going to be updating the protocols. And then we're going to be executing our SLRs closer to the date. And we're also going to have to do SLR updates, not just for the JCA, but for some of those national submissions, because we're going to have to keep monitoring the competitive landscape and the emergence of new comparators. For the JCA dossier planning and development, here's the important thing. In statistics, we like to talk about table listing and figure plans and our SAPs. We're going to have to work with all of our national country affiliates to plan for those table listing and figure plans. We're going to have mock shells. We're going to have programming and dry runs. We're going to be producing things. We're going to be checking that everything works and being ready for all of these different pieces. And by the way, we have to make sure that's all consistent with what we might do at the national level. So we've got non-JCA HTA analyses, we've got non-JCA analysis and execution, and we've got a plan for the dissemination of all these things. So are there some recommended best practices? A lot of it has to do with the fact that you're going to run a clinical trial. We know how to do that. You've got to plan for ITCs and SLRs, and we've got to start thinking of that as not a one-time thing, but as a living thing. But the key takeaways: proper prior planning for HTA is essential. Use of indirect treatment comparisons is going to be critical for value assessment. Different HTA bodies necessarily have different requirements and preferences, so plan for flexibility. Clear and transparent disclosure is key to building trust. And make sure you're being clear about that difference between regulatory and HTA nomenclature of pre-specified and post-hoc, because today's preparation is tomorrow's success. And the biggest key to that is anticipate your PICOs. Don't fight them, lean into them. It's about human nature of decision-making. It's a good thing, actually, to think about the fact that at the end of the day, patients are making decisions. Are we doing the best job we can of using the data that we can get access to, using the types of analyses we know how to do to help them make those decisions? So huge thank you to the organizers and to all of you for your attention today, but also to the cast of thousands. I have a great team at MSD. Many of them helped me put together some of the material in this presentation, which we are happy to share with you so that we can all work together on proper prior planning. Thank you.
Thank you so much, Lara. So thank you for setting the scene, educating us about the number of PICOs, the number of ITCs, and the pre-specification. That's very important. And we will continue that topic, and especially on ITCs. So our second speaker now is Antonio Ramiro Azocar. He's a statistical methodologist within the Biostatistics, Methods and Outreach Department at Novo Nordisk. His expertise lies in quantitative evidence synthesis, health technology assessment, and data fusion. And before that, he was a lead statistician for HTA at Bayer and an independent contractor to provide statistical support to CROs. He holds a PhD in statistical science and an MSc in machine learning from the University College of London. And his presentation now will be on considerations for methodological innovation for indirect treatment comparisons in the pan-European HTA. Antonio, the floor is yours.
Technical check first. Slide 2, slide 1. Okay. Okay, so yeah, my talk is about indirect treatment comparisons. So comparing treatments when there is no head-to-head trial between those treatments in pan-European HTA. So that is in the context of the new EU HTA regulation. And it's about methodological innovation. And I'm going to talk specifically about covariate adjustment. So in Greg Levin's talk from the FDA yesterday, it was pretty clear that covariate adjustment is desirable in the analysis of individual trials, even though it's not necessary. But in this particular case, I think that covariate adjustment is necessary by design. However, covariate adjustment is not that well regarded in this context, and I'm going to explain why. This presentation is split into 4 parts. The first one is the background, why I think that covariate adjustment is necessary for indirect treatment comparisons, specifically in the context of the new EU HTA regulation. The second part is about the perception of covariate adjustment in ITCs, why I think that it is poor, because the implementation and the reporting so far has been poor. And then the third part is about building fit-for-purpose covariate adjustment methods, limitations of existing methods and what we can do to improve them. And we will see that if we started from here, the methodology has evolved a little bit. The implementation has not evolved so much, and we have to take the methodology further while at the same time shrinking that gap. So that is a big challenge. And then finally, some suggestions and recommendations for future steps. Firstly, some terminology. Indirect treatment comparisons can be anchored or unanchored. We see that in the anchored case, there is a common comparator arm, and often we can preserve randomization if the trial comparing A versus C and the trial comparing B versus C, if they are both randomized. We can transport relative treatment effects from one context to the other. On the other hand, this unanchored comparison is more problematic because there's not a common control. Not only do we have issues of not preserving randomization at all, so this is similar to a single-arm trial that is externally controlled. But in addition to that, there are other sorts of issues such as time-related biases. And sometimes in the guidance, the term adjusted is used to refer to anchored, and the term unadjusted is used to refer to unanchored. But here I'm going to make a distinction. Here, unadjusted are analyses that do not adjust for covariates, and covariate adjusted analyses are those that adjust for covariates. And within the unadjusted ITCs, those would be the traditional meta-analytical approaches, standard fixed effects or random effects meta-analyses, naive comparisons in the case of the unanchored comparisons, which are particularly problematic. And then in the case of the covariate-adjusted ITCs, these are methods that explicitly adjust for differences in the distributions of baseline covariates across studies. For instance, we have matching-adjusted indirect comparison, which is a method based on propensity score weighting. We have simulated treatment comparison, or G-computation. That's a method based on outcome modeling. Different forms of network meta-regression. And then when we have subject-level data for all of the studies, there are the traditional causal inference approaches, such as propensity score weighting, G-computation, etc. Now I'm going to make a case for why I think it's important to perform covariate adjustment. So firstly, we are not adjusting for covariates. We rely on a very strong assumption, which is that of the unconditional exchangeability of evidence across studies. As such, analyses that do not adjust for covariates between studies are producing bias when there are imbalances in effect modifiers in the case of an anchored comparison, and/or prognostic variables in the case of an unanchored comparison. The standard approaches do not explain heterogeneity or explicitly produce estimates in any specific target population. And this is particularly relevant for the EU HTA regulation. And finally, they ignore uncertainty due to cross-study differences in baseline covariates. On the other hand, by adjusting for covariates, we can relax that exchangeability assumption to a conditional exchangeability assumption. We can reduce bias due to imbalances between baseline covariates across studies. We can also produce estimates that are specific to given target populations, which is particularly relevant for EU HTA regulation. And we can account for uncertainty due to the differences in baseline covariates across studies. In fact, the unadjusted approaches are often over-precise as a result of not accounting for these differences. And the conclusion is that, in my opinion, covariate adjustment is desirable for ITCs. Now let's talk about the specific HTA context when we are using ITCs for HTA or reimbursement decisions. These policy decisions are made for specific healthcare settings, and as a result, they should be made for relatively narrow, specific research questions with specific treatment versions, patient populations, and outcomes. And every effort should be made to reduce that heterogeneity so that the resulting treatment effect estimates are relevant to specific target populations. Now, within that HTA context, if we look specifically at the EU HTA regulation, the EU HTA regulation introduces a centralized framework for the joint clinical assessment of medicines, and this scoping process is very inclusive and aims to meet the needs of the 27 member states of the EU. And the assessment scope is determined by the EU states prior to consolidation. There's often a high variability in this peak of questions and very limited consensus on relevant subpopulations and comparators across states due to variation in clinical practice and reimbursement. So this example is actually even more outrageous than Lara's example. When we look at the number of analyses requested, there are 2 hypothetical oncology treatments, and based on evidence dossiers that are available, the number of PICOs was calculated. And as we can see, there is a very large number of PICOs. If we include outcomes per PICO in that computation, and without taking into account the NICE reports, the reason why NICE for England and Wales is also incorporated there is because often this submission will be prepared concurrently. We can see 280 for the first example and 720 for the second example. This is mainly driven by high variability in the target populations or subpopulations, and by high variability in the comparators. So here, let's focus on 2 elements of the PICO. Let's focus on the P, and let's focus on the C. In terms of populations, it's fairly evident that each individual state wants treatment effect estimates that are relevant to their specific jurisdiction, to the population in their jurisdiction. So that's why there are many requests for specific subpopulations. In the sense of comparators, however, there are also many differences in comparators due to differences in clinical practice, reimbursement, the standard of care that is available. Also sometimes off-label treatments that are not even EMA approved. So the conclusion is, because of these comparators, a lot of them will not have been compared in a head-to-head study. Indirect comparisons are required. And because estimates are required for specific target populations, covariate adjustment is required. And covariate adjustment is specifically desirable, particularly desirable, when we're relying on subgroup data, on very sparse networks where it is operationally feasible to perform, and with small sample sizes. And the target population has a fundamental role in scoping decision problems in UHTA. Covariate adjustment is necessary not only to try to reduce bias, but to maximize relevance with respect to a target population for decision-making. And as a result, the conclusion is that, in my opinion, covariate adjustment is necessary or desirable for ITCs in UHTA. Now, moving on to the second part of the presentation. And the conclusion of that second part is that the implementation and conduct has been poor. And why is that? Firstly, let's have a look at current perception in Europe prior to the new EU HTA regulation in terms of prices for covariate-adjusted ITCs. According to this review of HTA reports for solid tumor oncology treatments in England, France, Germany, Italy, and Spain, the overall acceptance rate of ITCs is suboptimal, only 30%. To be fair, this classification also includes this middle category where a submission was neither accepted or rejected as a result of the ITC. The rejection rate is a little bit lower, but 30%, we can agree that that is suboptimal. What is quite remarkable is that unadjusted ITCs are more commonly used than the covariate-adjusted ITCs, and the acceptance rate of the covariate-adjusted ITCs is lower. We have a 36% versus 33%, 76 versus 24 submissions. And this is in a therapeutic area where covariate adjustment is particularly appealing for several reasons. Firstly, we have single-arm trials, which are very prone to bias when we are performing a comparison across different studies, across different settings. So you would think that covariate adjustment is absolutely necessary in this case. We also have small sample sizes and we have sparse networks. A main challenge operationally when using the covariate adjustment approaches here is that they are difficult to integrate into a larger network of treatments and studies. But in this particular case, we have very sparse networks. So it's particularly surprising that in this area, covariate adjusted ITCs have not been that well received by the HTA agencies. And there are three common criticisms. The first one is that there is increased complexity and increased researcher degrees of freedom. The second one is that there is poor reporting and the lack of transparency in the decisions that have been made. And the third one is publication bias. And I know that publication bias is generally a problem in science, but in this case, it's publication bias with respect to the unadjusted approaches that do not account for covariate differences. And these issues undermine confidence in the underlying methodology. Of course, if you have increased complexity, increased researcher degrees of freedom, and on the other hand, you have poor reporting, well, that leads to these methods being perceived as untransparent. Firstly, when we talk about researcher degrees of freedom, when comparing the unadjusted approach versus the covariate adjusted approach, there are many things that we have to bear in mind. And there are many additional decisions, additional researcher degrees of freedom, which are not objective all of the times. In many cases, these are perceived to be subjective choices. Firstly, there is a methodology. Do we use weighting or do we use outcome modeling? Secondly, there are things like what covariates do we balance? What covariates do we account for? Do we balance means or do we balance higher order moments if we're using weighting? What's the specification of the outcome model if we're using outcome modeling? Also implicitly if we are using weighting. What is the target population? Do we have to refine some of the samples included in the studies so that the selection criteria of the studies match? Variance estimation, do I use bootstrap or do I use a sandwich error or do I use a delta method? When I'm using weighting, maybe I have to truncate the weights. Where do I determine the cutoff? What is the acceptable cutoff? When I don't have access to subject level data and I'm using an outcome modeling approach, I might have to simulate the covariates. How do I do so? So there are many, many additional choices and sensitivity analyses to assess the robustness of the analyses to these choices are often not reported. So that's the first thing, researcher degrees of freedom. The second concern is poor reporting standards. So the increased complexity and researcher degrees of freedom should require a more transparent reporting and implementation. According to a number of reviews, the rationale for covariate selection is often not discussed. It is often not discussed whether something is an effect modifier or a prognostic variable and why. In addition to that, covariate selection is very often based on what covariates are available from publications. And among studies using outcome modeling approaches, so there are only 18 examples here, but that is because outcome modeling approaches have only recently taken off. Normally, it was more weighting approaches that were used. Only 3 of 18 report details about the model selection or estimation, things like model fitting, diagnostics, which is concerning because these methods rely on the correct specification of an outcome model. And in many cases, we don't even know if that outcome model has correctly fitted the observed data, let alone how it is extrapolating. So this is a big problem. And finally, publication bias with respect to the unadjusted approaches. This is a publication by Cassidy et al., which they compute a standardized difference between the point estimates that have been reported for the unadjusted approaches and those that have been reported for the covariate adjusted approaches in this particular case. Matching adjusted indirect comparison, which is a weighting approach, we can see that on average, those point estimates, those bars to the right mean that it's favoring the covariate adjusted approach, and the ones to the left that is favoring the unadjusted approach. So there does appear to be significant publication bias in favor of the covariate adjusted approach. And I think this is partly due to the fact that covariate adjustment does require some sort of subject level data, whereas the standard meta-analytical approaches do not necessarily require subject level data. In order to adjust for covariates, you do need some level of subject level data. So, in summary, increased complexity and researcher degrees of freedom, poor reporting and reporting that is not transparent. This is perceived to increase uncertainty in the HTA decision-making process, and as statisticians, we have to think a lot of the times about the decision maker. A decision maker feels more comfortable when there is just only one way of getting to a particular decision, not 50. And the JCA guidelines suggest shifted hypothesis testing. I personally do not agree with this approach because, of course, why not? Let's add an additional arbitrary decision on top of that and what is a required shift in this case. But they do suggest that shifted hypothesis testing requiring a larger treatment effect to offset or penalize the additional uncertainty. And it makes sense that assessors might prefer simpler, more familiar methods if these are perceived to be clearer, more transparent, more convenient. And finally, they might prefer a more laissez-faire approach to heterogeneity with a typical risk of bias tools and the standard meta-analytical approaches, where biases are documented and evidence is downgraded, rather than sophisticated covariate adjustment methodology to account for those differences. So now moving on to, and just some conclusions. Implementation reporting is suboptimal in current practice. And as I mentioned at the beginning of my presentation, we started off here. The methods have evolved a little bit. The implementation has not evolved so much. And now we have to get there while being mindful of this gap and trying to keep a balance between the implementation and the development and promotion of new methods. Now talking about fit-for-purpose methods, limitations of existing methods, and desirable properties for new methods. Covariate adjustment and causal inference methodologies continue to develop quickly, and these developments will eventually make their way into the ITC HTA space. I think that certain properties are desirable for HTA decision-making, and as a result, the methods that have those properties should be preferable and are arguably better. Let's look at the current methods that are available. This slide is a little bit heavy, but there are 2 paradigms for covariate adjustment, so to speak. We have the outcome modeling approaches, which model the conditional outcome expectation, where the outcome expectation is conditional on covariates and potentially treatment. And we have the weighting approaches where trial or study assignment is modeled as a function of specific baseline covariates. Outcome modeling is said to be more precise and more efficient than the weighting approaches in the sense that you would have smaller standard errors and narrower interval estimates. However, this comes as a result of extrapolation. Weighting will give you wider interval estimates and poorer precision, but does not extrapolate. So we can argue that it gives you a more honest reflection of the uncertainty that is there, which is something that is relevant for HTA decision-making, appropriately characterizing uncertainty. When it comes to bias robustness, it is difficult to check whether an outcome model is correct. It is even more difficult to see whether an extrapolation is appropriate. At least in the case of the weighting methods, we can check for balance between baseline covariates, and that gives us an idea more or less about whether bias due to imbalances has been reduced. However, an issue with weighting is that in many cases there are small sample sizes and there's very limited covariate overlap, which massively reduces the effective sample size. And in some cases, there's not even a solution to the problem when we try to balance higher order moments. There are convergence issues. And there in that case, you need some treatment effect estimates for HTA decision-making, and extrapolating to some extent can allow you to produce those estimates. Limitations of the currently available methodologies. Well, these are strongly parametric approaches based on parametric assumptions. There are also singly robust approaches, which are relying on the correct specification of one model, whether that be a trial assignment model or whether that be an outcome model. And of course, these parametric assumptions are in many cases difficult to substantiate and fail to reflect the complexities of the real data. And if the parametric model is incorrectly specified, there will be bias. And the bias does not decrease with sample size at any rate. And the coverage will also decrease as the sample size grows. The probability that interval estimates actually contain the true estimate drops to 0. Limitations specifically of methods such as matching adjusted indirect comparison, MAIC, and STC is that they have been designed in a scenario where there is limited access to subject level data, and it's not that easy to produce estimates in a target population that is not the comparator study population. And well, the comparator study sample, in fact. And firstly, that comparator study sample in the green box at the top might not necessarily be representative of the comparator study population if sampling has been non-random. On top of that, it might not be representative of the decision-making target population. And this comparator study population may defer to the target population in the jurisdiction of interest. And I have just made many points at the beginning of my presentation saying that this is a particularly important consideration. But a new method has been introduced, multi-level network meta-regression, that through this very clever integration trick does allow you to produce estimates in specific target populations, not necessarily in the study samples that have been included in the meta-regression, but also in external target populations by marginalizing over those target populations. So I think that this method, MLNMR, is clearly relevant for the EU HTA regulation when you have multiple PICOs and multiple target populations that might be of interest, not necessarily those of one of the studies in the meta-analysis. However, we have to bear in mind that it's still a singly robust estimator, which is depending on strong parametric assumptions and on the correct specification of one parametric model. So, I mean, in causal inference, there have been a lot of developments related to doubly robust methods, such as the augmented odds weighting approaches, or TMLE. And these might provide greater robustness because they offer two opportunities for correct model specification. There is one model for the conditional outcome expectation, conditional on baseline covariates, and then there's another model for trial assignment. And we only need one of these models to be correctly specified to achieve unbiased estimation. In principle, these methods should be less prone to model misspecification bias because they offer two opportunities for correct model specification, and therefore they increase the space of acceptable estimators, so to speak. And nevertheless, we mentioned that very rarely a parametric model is correct. It will most likely be wrong. And if we combine two working models that are wrong, that are likely incorrect, then of course that the doubly robust method is still subject to bias. So here is where I think that data adaptive estimation, so more flexible machine learning methods in combination with this doubly robust framework, do show particular promise. For instance, doubly robust frameworks such as TMLE, in combination with the data adaptive estimators, provides good precision and efficiency while limiting unreasonable extrapolation in poor overlap situations, which is not something that happens when you have exclusively your outcome modeling G-computation estimator. It provides good finite sample performance. What I mean by this is when you combine a singly robust estimator with a machine learning approach, usually because the data adaptive approaches, they converge much more slowly than the parametric approach would to the true value. That leads to poor performance in finite samples when you combine a singly robust approach with a machine learning estimator. However, when you do this for a doubly robust framework, this allows for the slower convergence of models, while allowing you to keep bias low in small samples. And finally, for valid inference and uncertainty quantification, it might be necessary to apply a sample splitting or cross-fitting approach to relax the conditions and weaken the restrictions on the algorithms that can be used with this approach. However, there's just not a simple solution in all of these slides, because we talked before about poor transparency and poor reporting and about how there was this gap between methods development and methods implementation. And now I'm opening the door to many more researcher degrees of freedom, right? I mean, I'm automatizing the model selection process, but now I'm including a lot of different factors in the equation, such as the choice of the algorithm, hyperparameter settings. There's an example: algorithm choice, hyperparameter or tuning settings. And also, this is something that I think is often overlooked, but in my opinion is very important, that some of the data adaptive approaches, they depend on random number generator seed values. I think that having an approach where your treatment effect depends on the seed value is particularly concerning, especially for decision makers. As I mentioned earlier, algorithm choice, there are approaches to stack the candidate algorithms, such as the superlearner. This stacks the algorithms using an ensemble approach and sort of picks the best performing one. And then I think that some of these choices can be addressed through sensitivity analyses and also outcome blind simulations. But even TMLE with superlearner, which is one of the recommended approaches for doubly robust adjustment with machine learning, requires choices about the candidate algorithms, their tuning parameters, the cross-validation scheme, and the loss function. So again, opening the door to more sophisticated methodology that might remove some structural assumptions, but opening the door to many more researcher degrees of freedom and perceived lack of transparency. So the conclusions of this final part are that the current covariate adjustment methods make strong assumptions. They might be subject to bias. There's definitely room for improvement. I think that there is a method here, MLNMR, that can be clearly integrated into a large network of treatments and studies, specifically with limited subject level data. And there's the only method at the moment that can provide treatment effect estimates in a network and in any given target population. And then there are doubly robust data adaptive estimation approaches that do show a lot of promise, but it can be challenging to integrate these when we have subject level data that is limited and also within larger networks of treatment and studies. And finally, data adaptive estimation can automate certain aspects of model selection, but introduces other researcher degrees of freedom and has its own set of challenges with respect to transparency. So some conclusions and some recommendations for future steps. The EU HTA regulation will result in much greater analytical complexity in terms of the number and the sophistication of the indirect treatment comparison methodologies that are required. I think that there is a need for indirect treatment comparisons, specifically for covariate-adjusted indirect treatment comparisons, but there is also a need for the development and promotion of new methods than the ones that already exist. There is a need to train statisticians, not only in industry, but also in terms of the HTA bodies to keep pace with the methodological developments. There is a need for more people working on strengthening and updating the guidelines and reporting recommendations as well, not only in fancy new methodology. And to expand capacity, resources, and capabilities, not only in industry, but also within the HTA staff and committee members assessing the evidence. In my personal opinion, what really helps is prospective ITC planning, pre-specification at the trial design stage, where potentially as part of a HTA-specific analysis plan. And this helps you, because when you're writing a statistical analysis plan, it needs to be written in a way that in 5 years or in 10 years, someone's going to look at it and someone's going to understand perfectly the choices that you made and what you did, hopefully. So this helps you think clearly about the researcher degrees of freedom in the methodology implementation, improve transparency, and finally elicit important baseline characteristics that you might need later on for your ITCs. However, this requires workable and predictable PICOs at the time of writing this SAP, and that there's also some transparency with the evidence-based methods that the HTA agencies are hopefully using to determine these PICOs, and also engaging with the pharmaceutical company or the health technology developer throughout the process, which I think has been challenging so far in the context of the EU HTA regulation, but hopefully we can work together to make it happen. And with that, I conclude my presentation. Thank you very much, and the Q&A will leave before the end.
Thank you very much for this very interesting presentation on methodology for ITC. So we will have a short coffee break.